Okay. So my name is Raphael Mlauzi. I'm a registrar in the division of otolaryngology here at the University of Cape Town. So I obtained a consent from the patient for this presentation, and this presentation is referenced to Scott Brown 8th edition, and I've included other references where appropriate. So my patient is a 32-year-old male who had no comorbidities, HIV and COVID negative, who presented with progressive left forehead and eye swelling for about a year. He was saying it was increasing in size gradually. And when we saw the patient, he said that over the last month, he was starting to feel some pain, though all this time it hadn't been painful. He didn't have any nasal symptoms. He had a normal vision on that eye. Didn't have any headache, fever, or loss of weight. There's no clear history of a head trauma and no history of endoscopic sinus surgery. This is the patient, the photo of the patient. He had a GCS of 15 and was quite well looking, apart from the left periorbital swelling, which was fluctuant, a bit tender and erythematous, as you can see. Otherwise, the eye had normal movement, he had normal vision and didn't have any protosis or chemosis and didn't have any diplopia. And there were no external scars to indicate previous external sinus drainage procedures or trauma. The CT scan, as you can see, it showed a lobulated, a solid mass with mild enhancement arising from the left ethmoid sinuses and extending anterosuperiorly. There was associated attenuation of local bony tabnets and the left frontal skull. There was also extracranial extension into the left frontal and preseptal soft tissue, as we can see on the axial image there. However, there were no associated calcifications. The left bony orbit showed no retroorbital space-occupying lesion or fat stranding. There was also associated opacification of the left anterior ethmoid, frontal, and maxillary sinuses, but there was no intracranial space-occupying lesions or collections. So I'll open this up for any differential diagnosis. I'll open it up, Matthew, for anyone to give their opinion on what this could be.
Perhaps Simon Honnett can give a differential. Simon, you're muted. Okay, I think Simon might be having technical issues, Raphael. I don't mind trying then. I think the main differential based on your CT scan and the clinical presentation would be a frontoethmoidal mucocele. Within that differential, you'd include probably allergic fungal rhinosinusitis, although probably not the right age group. Perhaps a fungal ball or mycetoma, but again, it doesn't look localized, and the CT scan's very atypical. And then again, not with that typical CT scan features, but in that region, you'd consider other sinonasal tumors, congenital tumors being things like dermoids and epidermoids. More on the malignant side, lymphomas, rhabdomyosarcomas, again, would have a more invasive, aggressive features on your CT scan. And again, in that region, one would also potentially be worried about something like an encephalocele, but again, that CT scan is not suggestive of an encephalocele.
Okay, thank you, and that was our line of thinking when we saw the patient. We were thinking of the sinonasal tumors, which can either be malignant or benign. So the sinonasal tumors can be divided into epithelial, which can also be benign, malignant papillomas, squamous cell carcinomas, You can think of vascular tumors like hemangiomas. You can think of also salivary gland, like pleomorphic adenomas of the maxillary sinus. You can think of mesenchymal tumors, fibroma or lipoma, or neuroectodermal tumors like schwannoma, neurofibroma. And also tumors of muscle origin, leiomyoma, rhabdomyoma, and as you have said, even rhabdomyosarcoma. Though these are very rare tumors. We also were thinking of with the tenderness, it could be a mucocele, as you said, or with the tenderness, it could be a mucopyocele, and also fungal disease, allergic fungal sinusitis, or other invasive fungal disease, mucormycosis. And also rarely you could get a cholesterol granuloma. So I was holding on to this because I thought it would give away the diagnosis. We did a flexible nasal endoscopy and we saw some pus in the middle meatus. And after that, we did an aspiration and we managed to aspirate about 20 mils of pus. And we sent this for MCS. And we made a diagnosis of a frontoethmoidal mucopyocele. So after making the diagnosis, the next step was to consider a surgical intervention, surgical drainage, which we did. We did an endoscopic drainage of the frontoethmoidal mucopyocele. We did a left ancynectomy for access and limited meatal antrostomy. We did a frontosphenoethmoidectomy. The frontoethmoid mucopyocele was identified in the region of the frontal recess, and it was slowly decompressed. The mucocele sac was opened and widely marsupialized, and we left a pencil drain with a loose fit. And then we switched it to the 3O vicals so that there would not be any migration. So the histology came back as a fibro-osseous lesion, which they said, according to the histopathologists, which favored a fibrous dysplasia. But on the MCS that we sent, there was no growth. There were only neutrophils, and there were no AFDs. So we did an endoscopic approach here. Then I'd like to open up for what other surgical approaches are available depending on how complicated the mucocele is and its location. Because as we know, endoscopic approach might not be able to reach all of this. I'll open this up also for discussion. What other surgical approaches we can use?
Could I ask Mohammed to comment from Nigeria?
Okay. Good morning, everyone. In the case of mucocele, you can actually approach it endoscopically, and where there's no facility, we can do external frontoethmoidectomy to actually mucopylize the mucocele and actually put a drain there.
Okay. Yes, and any other additional approaches? Anyone else with other suggestions?
I think, Raphael, the question would be what kind of approach can you do in your unit? So it depends on numerous factors. So one is your experience, two is what instrumentation have you got available? So in many countries, maybe they haven't got a endoscope or endoscopic instruments. So the question is, can you do this endonasally, just with a headlight? Or would you have to do an open procedure like a front Lynch-Haworth incision to gain access? So I think that we're going to be limited by whatever is available. Okay. So we'll have to look at that first scan again and to see, whether anybody thinks that they would be able to do that through the nose, but without an endoscope, just with a headlight. Is there anybody that would attempt that? Show us that first coronal scan again, Raphael.
Okay. Yes, there it is.
So you could probably, I mean, it would be interesting to hear from our colleagues in other African countries whether anybody, how they would normally do this, you know, whether they would be happy to do this with a headlight.
But Kenneth, you want to comment from Ghana?
So I think you could, but obviously you know, if you have an endoscope, you would use an endoscope. But I think this would be accessible just using a kind of a headlight as well, or a microscope. Okay, you want to carry on?
Yes, thank you, Prof. So in terms of other approaches, we did the first one endoscopically. Then you can also do a modified endoscopic Lothrop procedure, also known as a draft 3. This will be for more complex frontal sinus mucocele, where there is loss of a lateral support in the frontal recess. One can also do a combined approach, endoscopic and external, where there are thick bony septations that might not allow for endoscopic techniques alone. One can also, as mentioned by the other speaker, you can also use a Lynch-Howard approach. It can be used to assess also laterally located frontal sinus mucocele. And also it can assist with the drilling down of bony septations. However, there is a risk of this procedure with the long-term frontal outflow obstruction and the recurrence of the mucocele. One can also do an osteoplastic frontal flap in combination with the modified endoscopic Lothrop procedure, also for mucoceles which are lying far laterally in the frontal sinus. And with the latest advancement in endoscopic procedures, one can, if the skill is available, one can do a transorbital neuroendoscopic surgery tones, specifically the superior eyelid approach. This is less invasive and also helps to address pathology of the lateral frontal sinus. This is likely fallen out of favor, obliteration of the frontal sinus, though it did have a high success rate. It is contraindicated where there's a posterior table erosion of the frontal sinus. So in terms of discussion points, our patient was stented with a pencil drain. The question is, would you do, after draining the mucocele white marsupialization, would one put a stent or not? I'm opening this up for any comments.
Mohammed, do you want to comment on that?
Okay. Yes, Prof. Traditionally, after frontal ethmoidectomy, external frontal ethmoidectomy, people use stent, they use Foley's catheter. But with advent of endoscope now, we don't use stent. Like when you do a lateral procedure or endoscopic draft procedure, we don't put stent because once you have an adequate drainage, you don't need to put stent in that. Like in this case, from the CT scan, I don't think if it will require any stenting also. Thank you.
Okay, what we did was we put a stent. What is important when we put the stent here is that it should be loose fitting, because if it's tightly fitting, then there's pressure necrosis around the drainage of the frontal sinus, the frontal recess, and then as a result of that pressure necrosis, the healing procedure with fibrosis and so forth, once you remove the stent, there is a chance that you can actually get an outflow obstruction, and then get again a recurrence of the mucocele. I'll let Prof. Luba comment on that one.
Thanks, Raphael. Yeah, so in the beginning, I never used stents. I mean, with these ones, and specifically with this case, you can really get a very wide kind of opening from your frontal sinus into the nasal cavity. But I've just learned that unless you have a mucosal flap that you can kind of cover over that defect or enter that frontal sinus, even if you've got a big opening, they tend to want to scar up just because of the infection, the inflammation in that area. So I'll always put a pencil drain in just for ventilation of that sinus, or a rain stent, even if it's just for a week or two. And it must be very loose fitting. If it's tight, it means that your opening is not large enough. So very important with these cases, you have to maximally open it. So really from the septum, so it will be similar to a type 2B draft that you would do, except that you don't have to do it. The mucocele has done your surgery for you. So as you open that mucocele, it essentially is a type 2B. You mentioned, so stenting, I would always advise it, even if you have a very, very big opening, just temporarily. When you mention a lothrop, it's very important to actually see whether the patient's a candidate for a lothrop. So you want to see, like in this case, have they actually got a frontal sinus on the other side? You know, is there any need to do such an extensive procedure? You know, it's very seldom necessary to do a lothrop. It might be indicated if you have a very lateral mucocele that's laterally located, and you need to come get to that mucocele via the opposite side. You might only have access if you go from the contralateral side, then with your instrumentation. But otherwise, there's not, or if you have an interfrontal sinus cell, so you have a midline cell, you know, between the two frontal sinuses, then I think a kind of a lothrop might be indicated. But usually it's very simple, straightforward surgery in these cases. In this case, the one thing that you need to watch out for as well, it's a very well pneumatized sinuses. If you look at that scan, your anterior ethmoidal artery lies below the skull base. So we can go back to one of those scans now. So you actually see what looks like the frontal sinus extending behind the anterior ethmoidal artery, and that's not the case. If you go to the previous slice, yeah, so if you look at so go back to the next one. So if you look at the right bottom corner there, the next slice, you can see the anterior ethmoidal artery there, and you see those pneumatized cells. Those are actually supraorbital cells. They're not your frontal sinus anymore, it's supraorbital cells. So you just need to be aware of that you don't try and open a frontal sinus in that area, because you will lacerate the anterior ethmoidal artery. So if you see an airspace above the orbit and at the level of the anterior ethmoidal artery, be aware it's a supraorbital cell and not the frontal sinus.
Professor Libber, the histology, if I remember correctly in this case, was that of fibrous dysplasia. So I presume it was a primary fibrous dysplasia with a secondary frontoethmoidal mucocele. Would that change your management at all? The fact that there may be underlying fibrous dysplasia?
Show us that initial scan again, the coronal. I think I would speak to the pathologist here and actually show them the scan. There's nothing on this scan that makes me think it's a fibroosseous lesion. So I think you might have had a pathologist that just looked at a piece of bone, you know, and it didn't get the whole picture. It's so important for your pathologist to actually have a good history and see the scan. So I think if one had to go back and ask them to relook at it, they might change their diagnosis. I see nothing here that really makes me think it's anything else. But even if there was fibrous dysplasia, even if the scan looked different, it was a different patient, we wouldn't manage that surgically unless it causes compression of a structure, compression on the orbit. For instance, if you had a medial orbital wall here that was involved with fibrous dysplasia bone, and you had a patient who had pain or proptosis, I would remove that part off. So you would just remove the part of the bone that actually causes problems.
Then one last question on the topic of stents. Have you any experience, and would it be appropriate in such a case to use the drug-eluting, the steroid-eluting stents?
I think so. I think that with any stent, you just want, essentially, you just want something to push your flap over the edge, so over the little bony, exposed little bit of bone that you have there. And I think the drug-eluting stents would be very useful for two purposes. One, to get a little bit of steroid and reduce the inflammation, but also just the stenting purpose. The problem is they're so expensive. So even if they were available here, I probably wouldn't use them for this indication, because a rain stent or a pencil drain is so cheap, and it does exactly the same thing.
Thank you.
Thank you, Prof. And then there's a question of the cosmetic defects post-drainage. Because even if after you drain these patients, that swelling continues to be there, is there anything one can do about it? Can someone just observe it over time, which is what we do at our institute, just to also learn what other people are doing about that one?
So I think if you have a mucocele like this, where you have the medial wall of the orbit being kind of lateralized, you know, so, and you have a cosmetic deformity due to that laminar papyracia, I don't think there's anything wrong with fracturing that laminar papyracia or partially removing a little bit of bone that might be causing that. But usually it remodels, so you need to do very little. You'll find over a period of a year, 2 years, that there might be, you know, that patient will improve completely without you doing anything. So we do very little, but I would, if I'm right there and I can see the laminar papyracia and it has been kind of out fractured or remodeled, then I think I would do something there. But I wouldn't go and do a big procedure like, you know, put a graft in, for instance, in the inferior wall of the orbit. I wouldn't do any kind of reconstructive work in these cases, not initially.
Okay. Thank you, Prof. So as I've said, that one can allow the orbit to gradually reduce, unknown for what period of time, and if it fully resolves. Some centers practice medial optical decompression at time of initial surgery, as Prof say. And then in terms of follow-up, these patients, how often do we need to follow them up? Any volunteers?
Dr. Fui, do you want to comment on that?
Yes, Prof. So down here, what we do is I follow them post-op. I see them in the clinic, and then do a bit of cleaning and debridement in the first 3 weeks. They do the nasal douching afterwards, because I don't like to, as Prof will recommend, you don't go towards the osteum very much to cause a lot of inflammation there, which may lead to subsequent stenosis. So the nasal douching is very important. And then around 6 weeks, we see them again. And when you find that everything has settled, or if there's a stent, you take it out. Then I don't go beyond the 6 weeks after the stent is out. Maybe I see them one more review, and then I discharge them from the clinic. I don't know if Prof will add anything to that.
I think you're doing exactly the correct thing, Kafui. Nice to hear from you again.
Okay, thank you. And I just want to talk a few slides about the mucoceles. The definition is that a mucocele is an epithelial-lined mucus-filled sac within one of the paranasal sinuses, with the expansion of the sinus cavity and remodeling of the sinus walls. There are two factors to the pathogenesis. The first one is that there should be sinus outflow obstruction. Then once there is an obstruction, then within the sinus, with the mucocele, then there will be an inflammatory process within the sinus itself. So within the sinus itself, then there's an inflammatory process. And then in terms of sites, the frontal sinus is the commonest involved, mainly because of the narrow drainage from the frontal recess. The second most common one is the ethmoid, and then the maxillary and sphenoid is the least involved. In terms of etiology, sinus surgery is the leading cause, especially frontal recess surgery and external frontal ethmoidectomy or the Lynch-Howard procedure. And this is because of loss of lateral support of the frontal recess. And also there's orbital fat herniation into the sinus, which leads to obstruction. Also, there's been reports of mucoceles following scalpel fracture repairs in children. And the second commonest etiology is trauma, and they can also be spontaneous and also tumors. This is the latest series that I saw that looked at 255 cases. And out of those, about 2/3 had prior sinus surgery, 17% had spontaneous causes, and 14% had prior trauma. And only 2% had chronic granulosinusitis without surgery, and 1% the cause was tumors. So in terms of the clinical features, it depends on what sinus is involved. But the commonest symptoms are ophthalmic, with periorbital swelling, pain, exophthalmos, limited ocular mobility, visual disturbance, diplopia, optic neuropathy. Fortunately, our patient didn't have many of these, only had like a periorbital swelling and pain. And he had good ocular mobility, good vision, and no diplopia. However, if the mucocele is affecting a concha bullosa, you can get nasal symptoms like obstruction. And one can get a cystic swelling in the medial canthus and epiphora if there is involvement of the nasolacrimal duct system, if there's a dacryocele. And they can also present with a cosmetic deformity, as we have said. So in terms of radiology, on the CT scan, the lesion is usually homogeneous and isodense with an expanded sinus. And there's a bony remodeling of the sinus walls because of the inflammatory process within the mucocele. And there's a contrast enhancement with the paracel because of a raised protein content. Frontal ethmoidal mucoceles can show on CT scan with a bony defect of the laminar papyracea and also a defect in the superomedial part of the orbital rim. You can also be able to see globe displacement, usually laterally or downwards. You can also get erosion of the posterior table of the frontal sinus and compression of intracranial contents if the posterior table of the frontal sinus is eroded. MRI is mainly used, it's not done routinely, but one can consider doing it to delineate mucoceles from soft tissues, mainly brain tissue, where there is erosion of the posterior table of the frontal sinus on CT scan, or where there is erosion of the laminar papyracea. Because of the variability of the mucocele content, images on the MRI can be confusing. A mucocele usually have a hyper intense image on T1 because of the high water content. But then if it gets infected, like in our patient, then you tend to get a high protein content. And so there's variable intensity on both T1 and T2. Thank you very much. I'll open up for questions and comments.
Okay, right. Okay.
Thank you very much, Raphael, and an excellent presentation. Professor Lubbe, would you like to make, I know you wrote a chapter on mucoceles and Scott Brown, would you like to make any final comments?
I think it was good. I mean, I normally would follow these patients up to until about 3 months. Here, not wide opening at 3 months, then I think you can safely kind of discharge these. I think it's also just important to maybe assess each case and find out why the patient developed a mucocele. You know, was it due to stenosis, due to either trauma or previous surgery? But don't forget that you can get mucoceles in other areas like the sphenoid sinus, maxillary sinus, frontal sinus, due to something obstructing that sinus. So either benign or malignant. So just always keep that in mind.
And then, Professor Lubbe, there's an earlier question regarding what is the scarring like with the Lynch-Howard incision. I know one of the drawbacks where the Lynch-Howard is done for other reasons is the higher incidence or rate of frontoethmoidal mucoceles. Perhaps you can answer that, and are there any alternative, could you do this just via a smaller precurruncular alternative incision other than the Lynch-Howard?
I think the biggest factor here is however you do it, you have to establish patency between the mucocele cavity and the endonasal cavity. So there's no, if you used a transorbital or precurruncular approach, for instance, you might be able to drain that, that mucocele, but the question is, are you going to be able to get a good communication? So I don't think I would advise that as a kind of a first step. I think you always need to make sure that you've established that. What was the question there? I missed just ask it again.
The actual question was, what is the scarring like with the Lynch-Howard incision? But
yeah, so the scarring depends on, that depends on many factors. It depends on how you do it, if you have a little gull wing, but it also depends on ethnicity. For us here in South Africa, there's a lot of people that develop keloids. So you might have one person that doesn't scar, and you might have someone else that develops a keloid. And then you also get that webbing. So I would, we very, very seldom would do a Lynch-Howard now. So it's not just the scarring. With the frontoethmoidectomy, you also have a risk of removing too much bone of that lateral, of the medial wall of the orbit. And what happens, and that's why a complication of external frontoethmoidectomy is actually a frontal mucocele, because you have the actual orbit kind of prolapsing into that frontal drainage tract, and that's what causes your mucocele formation. So that's almost the only indication for me to do an endoscopic Lothrop for these patients, because that's the only way then you can widen that drainage pathway right to the other side, to the laminar preparation on the other side. So for the patients that I've seen that have had external frontoethmoidectomies for whatever reason, and they develop mucoceles, those patients need endoscopic Lothrops.
Thank you very much. Professor Fagan, any last comments?
No, I think it's dangerous if I commented on rhinology cases, so I've got nothing to add.
Okay, so thank you very, very much, everyone. There doesn't seem to be any last questions, so I'm going to end this meeting now.